This next session, the title of this next session is Street Homelessness, Mental Illness, and Drug Addiction, and it is going to be moderated by the person who sort of start to finish organized, brainstormed, and is the locomotive behind today. And for that, I would like, if we could all just join me, giving a little shout out to my colleague, Jalu, Streeter, who organized the whole day today. So Jalu is going to be our moderator. She worked incredibly hard these last several months to get up to speed on this very complicated issue and to reach out to some of the, just most knowledgeable and effective people on the front lines of the sort of nonprofit, government, practitioner, academic, leaving some community out, journalism, the whole thing. So I'm super grateful. So Jalu is the director of partnerships here at CEPR and is also a research scholar at CEPR. And her work, she works with potential partners to connect CEPR's community of scholars and faculty and others and supporters to try to make progress on pressing economic policy issues. So to the extent that after today you think that there may be some way for your organization or organization you know of or someone else to potentially partner with CEPR, feel free to reach out to me, or especially Jalu, who's much more effective than me, and we could, we're very open to collaborating. This is not an issue, homelessness, that CEPR has historically done a lot of work on. So I did get some reactions of, really, you're doing a policy forum on homelessness? But I think it's a super important issue, and I would like to energize somewhat my research community of economics to try to contribute more in this space. With humility, recognizing economists, we don't know everything, so but her work Jalu's work has primarily focused on the economics of aging, retirement security, and financial security, and on the mental well-being of older adults. And she received her PhD in economics at Indiana University, Bloomington, and before coming to Stanford, well, here at Stanford before CEPR, she worked at the Stanford Center on Longevity, and before that, she was an economics professor at Allegheny College in Pennsylvania. And so with that, please join me in welcoming my colleague and friend, Jalu Streeter. Moderator.
Thank you, Mark, so much for that kind words. I have to say, without your encouragement and your support, I wouldn't have made it this far. And also, without the support of every one of you here, I also wouldn't have made it this far. But I think at the end of the day, it's not my accomplishment or anything like that. I think we're facing a tremendously important issue together, and we just have to work together to solve all the problems. Maybe not today, maybe not this year, but I think this is a good start. So now, let me lower this because Mark is so much taller than me. So now let's move on to the next panel with a special focus on mental illness and drug addiction among the unsheltered homeless. We have a great panel, Dr. Anna Lemke, over there. So she is a professor of psychiatry at Stanford University School of Medicine. She's a professor. She's also a clinician, a speaker, and writer. Her book in 2016, Drug Dealer MD, was highlighted in the New York Times as one of the top 5 books you must read in order to understand the opioid epidemic. Her new book, Dopamination, this one, right here, I have read, and it's a great book. I love it so much. It's an instant New York Times bestseller. The book explores how to moderate compulsive overconsumption in a dopamine overloaded world. Indeed, we're all addicted to something, right? Drugs, food, smartphones, working, shopping, you name it. I don't have substance abuse disorder or anything like that. But reading this book really made me reflect on my own vulnerabilities, on my own dark sides, and my own chase of dopamine. Next up is Lisa Daly. She's right here. Lisa is the executive director of the Treatment Advocacy Center, which is a nonprofit organization aiming to improve the lives of those suffering from mental illness. Lisa joined the Treatment Advocacy Center in 2015, bringing many years of nonprofit policy and advocacy experience. Her prior work includes the representation of refugees seeking asylum in the US and many years of experience as a litigator in the areas of human rights and civil liberties. Last but not least, Michael Schellenberger. Where's Michael? Oh, there. Michael Schellenberger is the founder and the president of Environmental Progress. His new book, San Francisco, this one, which I also read and I also love, has brought national attention to the humanitarian crisis in Californian cities, where homelessness, crime, addiction, and the mental illness are on the rise. Michael's book not only provides a large amount of data, but it also tells vivid stories of real people. I want to mention that one of the real characters, Thomas Wolfe, is joining us in the last panel starting at 4:30. Thomas is right there in the back. So I want to emphasize that Michael is here today to talk about policy issues. He's also, many of you probably already know that he's also running for California governor. Stanford University is a nonprofit educational and research institution, and therefore at this policy forum, at least on stage, we will not discuss anything related to his political campaign. So now I would like to invite each one of them to probably come on stage and give their 5-minute summary of what they think are the problems related to mental illness and drug addiction. So I think first up is Lisa.
Hello, I do not have slides. I figured 5 minutes is too short for slides. So Treatment Advocacy Center has the mission of eliminating barriers to the timely and effective treatment for people with severe mental illness, whatever they are. We focus on people that have diagnosis of schizophrenia, schizoaffective disorder, severe bipolar disorder, or really any kind of an illness that has psychosis as a component. And we focus on this population because their needs are really different than the needs of people that don't face that challenge. And those needs are often overlooked when we are putting together our policies. Neglect of this vulnerable population can and does lead to tragedy. And homelessness is just one of those tragedies. But of course, that does encompass other kinds of tragedies like the rampant victimization of people on the streets, death due to untreated health conditions or overdose, and of course the wholesale criminalization of psychiatric symptoms that we see every day. The LA Times recently reported that 51% of homeless population in the city reported mental illness, and a whopping 67% reported either mental illness or substance use disorder. That is probably an underestimate based on other data that's available. People in California seem to be reaching a kind of critical mass with the issue of street homelessness, and they want to see something happen that is going to fix the problem. I can't offer a solution that is going to fix homelessness because homelessness is not a single problem. But I can give you a couple of policy changes and a couple of ideas about things that would actually help for the population that I know about, which is individuals that have severe mental illness. The main solution is at least partially pretty obvious, and that is treatment. But within the broad category of treatment, we need to understand that this really means two different things. It means treatment capacity, but it also means having the will to intervene if we have to do so. In 2016, which is before the recent jump of over 1,000% in the number of people who were found incompetent to stand trial, 75% of California's state hospital beds were occupied by people who were in the criminal justice system. And they're generally there for really minor offenses, things that we call nuisance crimes. And they're related in a lot of ways to homelessness and to the parts of life that go along with being homeless and being able to maintain just a getting by existence. So like I said, these are very minor offenses, but these are people whose mental illness is so severe that they can't be adjudicated. So most of these people are in beds and they're either waiting evaluation or restoration for competency. So to be clear on what that means, it means we are trying to make them well enough to complete a criminal case, but we are not trying to make them well. If you don't treat people who are really sick, a lot of them are going to end up in jails and prisons, and a lot more of them are going to end up homeless, or they're going to go back and forth between the two. Severe mental illness is characterized by major cognitive functional impairments and emotional disturbance, sometimes both. So the fact that this often leads to people being criminalized or ending up homeless is not rocket science, and it really shouldn't surprise anyone. It doesn't always get expressly stated, so I will say that one of the solutions is adding additional hospitals and beds. That actually will help get some people off of the street if the reason that they're homeless is because of untreated mental illness. More beds do actually need to exist. But the second part of the equation is that we need to stop planning and operating our public mental health system in a way that we already know excludes the most severe cases. We do this as if they're not part of the equation and really should be somebody else's problem. And this is how we ended up with a situation where the LA County Jail and the Cook County Jail are the largest public mental health institutions. Research indicates that over time, people who are admitted to state hospitals in recent years have been much more likely to have had prior arrests than prior hospitalizations. That means that our system's response, our systemic response to mental illness has shifted away from what it used to be, because believe it or not, it actually did used to be a medical or social services response, to becoming what it is today, which is primarily a law enforcement response and a criminal justice response. Why are we okay with that? Because we are okay with that. Otherwise, we would not have allowed this to continue for as long as we have. There's some advice that people often give to people who are earlier in their careers that I think is really relevant here, and this isn't the first time that I've brought this up. The advice is, dress for the job you want, not the job you have. This is really good advice for like an ambitious young professional. This is terrible advice and a terrible strategy for building a public mental health system. But that's what we've done. Our system is designed for the patients that we want to have and the clients that we want to treat. It's not designed for the ones that we actually have, or at least it's definitely not designed to be able to help all of the ones that we have. Access to treatment is limited, and basically, especially intensive treatment, is really skewed towards people who are doing well enough to recognize that they need that treatment, and doing well enough to actually figure out how to find that treatment and ask for that treatment. That means that the people with the more complex needs and with the highest risk for death or decompensation on the streets are virtually invisible to the system. We step over very sick people who are sleeping in doorways in order to get inside, and then we close the door. And we won't open that door unless they knock for it. That's what we need to change, and until we do that, we're going to have an unmitigated human rights catastrophe on our streets. Nothing is going to change until we can change that way of doing business. Thanks.
Yeah, no problem. Hi, everybody. It's great to see folks. I was told I have 5 minutes. And what I want to do in that time is talk about the ways in which I think an understanding of what's happening in the brain of people who become addicted and who have co-occurring mental illness can help inform our policies. So very briefly, I'm going to also talk about how understanding the brain, as well as how it interfaces with the world that we live in now, is also very important to consider. I base that on my study of the brain, but also on many years of treating people with addiction and co-occurring severe mental health disorders. My disclosures: I have been retained as a medical expert witness in federal, state, and county opioid litigation. I do not receive any funding, fees, stock options, or other compensation from companies that make, market, or disseminate medical products. There are many risk factors for addiction that can broadly be categorized as nature, nurture, and neighborhood. Nature is the inherited piece, the co-occurring mental illnesses that put people at higher risk for becoming addicted. Nurture is the way that we are raised, including early childhood trauma. And neighborhood has to do largely with what we often call now social determinants of health, very, very important, but also simple access. And one of the biggest risk factors for becoming addicted is whether or not you have easy access to a drug. It is very clear, based on many studies, that if you live in a neighborhood where there's easy access to addictive drugs, you're more likely to try them, and you're more likely to get addicted to them. Furthermore, if you have decreased access, you are less likely to get addicted, and policy interventions, which either increase or decrease access, have very real repercussions when it comes to the prevalence of certain addictive disorders. What we have here is a graph from the CDC showing the very clear correlation between an increase in sales of prescription opioids, increased treatment admissions for opioid addiction, and increased related deaths due to opioids. What you see here is not just correlation, but causation. As doctors in the late 1990s started to prescribe more opioids to patients with minor and chronic pain conditions, there were more opioids available, not just to those individuals, but also to others through diversion, leading to the opioid crisis that we are in today, which has now transitioned from prescription opioids to illicit opioids, including fentanyl. It's also true from historical examples, if you decrease access to addictive substances, you decrease addiction. When we think about prohibition, which was the making illegal the production and sale of alcohol between 1920 and 1933, most people don't know that actually from the perspective of addictive alcohol use, it was very effective. And what you see here is as alcohol became illegal, with prohibition, right here, maybe it's right around here, there was a massive decrease by half in alcohol-related liver disease called cirrhosis and alcoholism, also known as alcohol use disorder. So you decrease access and you decrease risk. So here is the central problem. We are living in a time of almost universal access to highly potent, highly reinforcing drugs. And when you combine that with what drugs do to the brain, as well as the inherent increased vulnerability in people who have a pre-existing psychiatric disorder, you come up with a very different policy conclusion, I believe, than you would if you had an environment where you had not easy access to those drugs, or you were working with patients who didn't have the vulnerability due to severe mental illness. So I want to just talk very quickly here about what happens to the brain as people become addicted. One of the exciting findings in neuroscience is this specialized reward circuit in the brain, mediated largely by dopamine released in this area, and the communication with the prefrontal cortex. So this is the reward system. Things that are reinforcing release a lot of dopamine. That gives us the pleasure. But the brain immediately adapts to increased dopamine by downregulating dopamine transmission and production, putting us in a dopamine deficit state. That dopamine deficit state is what then drives the craving and repeated reuse, not to get high, but just to feel normal. Furthermore, you've got the prefrontal cortex, which is a central part of this reward system. What is the prefrontal cortex? It's that large gray matter area right behind our brains, which is central to delayed gratification, appreciating future consequences, and autobiographical narratives. And what happens as people become addicted to drugs? The prefrontal cortex essentially goes offline, and they're no longer able to truly appreciate the consequences of immediate actions. And this has been shown again and again in numerous studies, both neuroimaging and psychological studies, experimental studies, that as people become addicted, they devalue long-term rewards, and they overemphasize or overvalue short-term rewards. All of this, of what happens in the brain, amounts to this part of the brain and the dopamine, especially that dopamine deficit state, being the primary driver of decision making, and this prefrontal cortex taking a far back seat. You might think of the brain as a car, This area is the accelerator. This area, the prefrontal cortex, is the brakes. And as people become addicted, their brakes stop working and the accelerator slams down. Why is this important? Because it acknowledges that the disease of addiction is a loss or a mitigation of personal agency. People lose their ability to choose. You may have heard of Prochaska's stages of change, this idea that people are in pre-contemplation, contemplation, action, and you can lead a horse to water, but you can't make it drink. But the truth is that when people are deep in their addiction, they don't have access to the data to make informed choices. So for example, when we see patients in the hospital who come in intoxicated, we say, are you interested in rehab? They are not interested most of the time because they're in withdrawal and they want to get out of the ED so they can get out of that dopamine deficit state. If we hospitalize them, sometimes against their will, and wait 3 to 5 days until they're out of withdrawal, their prefrontal cortex gets back online. Would you like to go into treatment? A lot of times we will get a yes in that instance. So this, I think, is really, really important when we're thinking about whether or not we're mandating treatment, whether or not we're incentivizing treatment, and to appreciate that there's a diminished capacity to really understand long-term versus short-term gains. One of my favorite experiments, I'm going to hurry up here, is an interesting study asking people to complete the sentence, when you envision your future, you will do X. And most people who are not addicted, when you ask them this question, they will describe a future that's about, on average, 7 years in the future. People who are in their addiction will typically describe a future that's about 7 days in the future. Again, just another example. All right, this is from a very famous study by Nora Volkoff, who's the head of NIDA, which is essentially showing the brains of people and their dopamine transmission represented by red. And you can see in these healthy controls in the nucleus accumbens, there's plenty of red, nice, healthy dopamine transmission. These are individuals who have been addicted to these substances, cocaine, meth, alcohol, heroin, and you'll see there's very little red. Importantly, these are individuals whose brains were scanned 2 weeks after stopping drug use. 2 weeks after stopping drug use, they still had not restored healthy dopamine levels. And this is really why, many times, why people will relapse, even if objectively you can see, and they can see, that their lives are better off. They're driven by this dopamine deficit state. This is a very famous image illustrating what happens to our brain in development as we go from early childhood to about age 20. And in this image, red does not represent dopamine transmission. Red represents the number of neurons in the brain, which is the workhorse cell of the brain. And what you can see here is that in young children, there are lots and lots of neurons. We're sort of like totipotent cells. And as we mature, the number of neurons decreases all the way up until age 25. Why? Because our brain is an efficient organism. We're pruning back the neurons that we don't use and myelinating in blue, that's like greasing the wheels, the neurons that we do, so that by age 25, we end up with our adult neurologic infrastructure that will serve us for a lifetime. So you can certainly imagine that if in this vulnerable period, as we're pruning back those neurons, that individual is exposed to addictive drugs, that will change their architecture. But also importantly, I love that Lisa talked about schizophrenia, a severe mental illness characterized by psychosis, for one. We do believe that one of the things that goes awry in schizophrenia is that this pruning process doesn't occur appropriately, so that people are left with significant frontal lobe or prefrontal cortex deficits. So if you think about a combination of a mental illness that interrupts healthy pruning and then exposure to addictive drugs that interrupts healthy pruning, you end up at age 20 or 25 with a very different and potentially unhealthy brain. All of this is what I believe we need to take into account as we're considering the way, for example, that the criminal justice system should interface with people who have addiction, and what kinds of places are healing places. And I will just leave as a little teaser that I have become convinced that we need to bring back mandatory locked facilities for people with severe mental illness and addiction who cannot thrive in a world of universal access to highly potent reinforcing drugs and behaviors. Thank you.
podium, or can I just stand? Thank you very much. I'm so glad that Anna moved the Overton window so far towards reopening mental hospitals. Everything I say now is going to sound very moderate to all of you. So thank you very much. It's a real pleasure to be here. I'm a huge fan of what's happening at Stanford. One of the main characters, I have to say nonfiction characters, real people that's in San Francisco, is Keith Humphreys. I'm also a huge fan of Andrew Huberman, who runs the Huberman Lab. He's completely changed my own daily routine. I now run before I drink coffee in the morning. A big change, and when I'm experiencing total misery on my run and hating it, I'm training myself to enjoy it. It's like the weirdest experience, but it actually works. And I'm also taking cold showers, which helps to regulate me. So I did both of those things this morning, and I'm in a state of calm attentiveness, which is what Andrew Huberman has encouraged us to be. I'm also a huge fan of Anna's. Her book is absolutely outstanding. I was saying before I read her book that really there wasn't that much new in addiction science. I no longer say that, especially after reading the book, but also Andrew Huberman. And thank you, Jialu, for inviting me. I don't always get invited to mainstream homelessness events, so it's a pleasure to be here. I want to make an argument that we are failing to deal with this issue for institutional and structural reasons. We spend more money on mental health in California and on homelessness of any other state per capita and have the worst outcomes. So that's a mystery. Why would that be? Is it because we don't care enough? I don't think that's the case. I think that most of us do care. When voters are asked to vote on ballot initiatives on homelessness or mental illness, we almost always pass them. We pass them, often we're just taxing millionaires, so it doesn't affect a lot of us. But we are often deciding to tax ourselves to pay for this problem. So I don't think it's the case that we don't care. I want to argue that it actually has to do with several key policy choices that have been made that have become dogma in the state. And I come to this after the research for San Francisco, which came out of a visit to the Netherlands, in particular to Amsterdam, where I am friends with a member of parliament, and her husband is a senior drug policy official who I asked about this question in 2019, and I returned to Netherlands several times to shadow him, to see his work with so-called homeless, people that were on the street, addicts, or people suffering mental illness. The first thing I want to argue is that we need a statewide psychiatric and addiction care system, a single statewide addiction care system that I want to call CalPsych. It would be a CEO, best in class, reporting to the governor with 6 regional directors and a cadre of assertive case managers who would be responsible to take care of difficult people throughout their entire process of coming off the street, through rehab or psych hospital, through shelters, to achieving their potential, whatever that might be. My aunt had schizophrenia. She lived in a group home. She drank coffee and smoked cigarettes all day long and flirted with the guys that worked there. Great outcome. Other people can be, great outcome. She never became homeless. She never became an addict. She never became a sex worker. Other people can become professors at USC, people with schizophrenia. That's amazing. So whatever is their own personal potential. I estimate, based on my own research and looking at a variety of other sources and interviewing people, I think probably somewhere like 3/4 of the people on the street who we call homeless are just suffering addiction. I don't think they have serious mental illness as we might define it in terms of schizophrenia or bipolar disorder. Those folks just need rehab. They need to get reaffiliated with family and friends. They need to get a job, and they can achieve their full potential as human individuals. There's other folks with some combination of those. It doesn't really matter, but I think what I want to draw attention to is the need for the single statewide system. Why is that? Well, the first is that it's expensive. This kind of treatment is expensive, and we need to be able to move people into different parts of the state because our systems for dealing with this in San Francisco, Los Angeles, San Diego, and other big cities, Oakland, their systems are overwhelmed, and they're not going to stop being overwhelmed anytime soon. A single statewide psychiatric and addiction care system might mean that, let's say, somebody overdoses on the street for the 3rd or 6th or 9th or 12th time. A CalPsych worker can be there, revive them, and say, Anna, we've revived you this many times. We can get you into rehab today and on a Suboxone taper into rehab in some outside of the open drug scene, because to Anna's point, of course, being around the drugs all the time is the worst thing for recovery. We can get you into 90-day, maybe 180-day, because we know meth addiction is very serious and difficult, inpatient rehab center outside of the open drug scene, and we can get you there now, immediate care. And we know that's such an important existential moment for people when they're deciding to get into recovery. I think the other thing I learned from the Netherlands, I think so often we demonize the police. We say we don't want the police to be involved with this. That's not really fair to the police or to the reality of the situation. Many people hit bottom in an interaction with law enforcement. So I think rather than seeing the police as the enemy, we should see them as part of the system. So the CalPsych worker who's reviving Anna could say, Anna, we can get you into treatment right now, but it's not mandatory. You don't have to accept treatment. People misunderstand my own view on this. I don't think treatment should be mandatory. But we should enforce laws, because if you don't enforce laws, people don't follow them. And if people don't follow laws, then you don't have a civilization. You don't have cities. And so that means that the person would have a choice. You can come with us into rehab right now. We get you on a Suboxone taper. Or my colleague, Officer Garcia, right here with the San Francisco Police Department, is going to arrest you because you've broken, we can see here, many laws. Open air drug use, public defecation, public camping, which, by the way, is illegal in San Francisco. People forget this. Public camping is actually illegal. It's only because the Board of Supervisors chooses not to enforce that law that it's not being enforced. And then the choice is up for that person. They can go to rehab or they can go to jail where there may or may not be a Suboxone taper. So it would say we need statewide psychiatric addiction care system. We need to enforce laws. Do we also need, as Anna and Lisa and others have argued, an expansion of conservatorship, a change to the Landerman-Petrus rules, something more than 72 hours, something longer for people? Probably. But to start, we can just enforce existing laws and get a lot of people into rehab right now with this broader care system. In fact, we think a disaster response to this could become the embryo of CalPsych. What do I mean by that? If we had 150,000 people on the streets of California, across California, living in tents, being sexually assaulted repeatedly, and by the way, in our research, the numbers of women that are sexually assaulted approaches 100%. A number of men are being sexually assaulted on the streets, 100%. Okay, if they were overdosing and dying and killing each other or being stabbed with machetes, we would say that's a humanitarian disaster. If it was happening because of an earthquake, we would respond within hours, not days. So if we responded to this in the proper way as a humanitarian disaster, that response, which could include a statewide psychiatric and addiction care system, triage tents to get people the care they need, shelter, that would then become the embryo of the statewide psychiatric and addiction care system, CalPsych. And it's just by creating a statewide system and enforcing local laws against the crimes that are being broken, the laws that are being broken. I think there's a third part to it that gets to this question of why is it that this disaster has gotten worse and worse, not better. We need to move away from a housing first policy. Housing first has failed. Those of you that advocate housing first, please explain to me how is it, if housing first has been the policy for 17 years in California, beginning in San Francisco since 2004, how is it that the situation has only gotten worse, not better? The traditional answer is we haven't spent enough money on it, but we keep spending more and more money and the problem gets worse and worse. In the Netherlands, they don't have housing first. They say they have some housing first programs, but that's not what it is. It's contingency management. One of maybe the best proven treatment of addiction using housing and other rewards. It was started in Birmingham, Alabama. It's very simple. You're in congregate shelter. You would like your own room like everybody else. Pass the drug test and you get your own room. Fail the drug test, you don't go back out onto the street, but you go back to congregate shelter. It works. Is it perfect? No. Does it work better than the current policy? Absolutely. And I saw it in place in Amsterdam with the social workers. Everybody wants their own room, a private room. Are you taking your psych meds? If not, we're not going to get you a private room. Are you passing your drug test? If not, you're not going to get your own private room. We arranged a job for you. You haven't been going. We're not going to give you a private room. It's contingency management, and we know that many addicts need that reward in order for their own recovery. But setting that aside, I believe that taxpayers also are also involved in this. Taxpayers are actually really tired of what's going on. They're sick of the chaos, and they are a factor in this. And if we don't take taxpayers and our fellow citizens seriously and are just completely client-focused, then we're headed for some real trouble. So this needs to take into fact that cities are not just for addicts and drug dealers. They need to be for all citizens. You know, it was just, when I moved here in the 1990s, there were so many smug conferences held at Stanford and Berkeley and San Francisco describing how we are a model for the world with our livable, walkable cities. Green, livable, walkable cities. Well, there's two parts of downtown San Francisco that are not livable or walkable right now, south of Market and the Tenderloin. I was 7 minutes into a walk through the Tenderloin with a reporter from the Times of London, and we see a guy overdosing, face turning blue, being rolled out of a tent. Yeah, we got Narcan to him, and we called 911, but this is unacceptable. My 16-year-old daughter can't walk safely from a BART stop in downtown San Francisco. That should be our criteria. Can teenagers walk safely in your downtown? They can do that in Amsterdam. They can do that in Amsterdam, Frankfurt, Lisbon, Vienna, Zurich. Don't take my word for it. Look up open drug scenes on Google Scholar, and you'll see that every one of those cities shut down the open drug scenes, and they did it the same way with social workers and police officers, shelter first, housing earned, universal psychiatric and addiction care. We can do the same thing in California. We are all so much better than the humanitarian disaster taking place on the streets. Thank you very much.
I'm going to take the first one. So you can sit maybe here. I'll sit here.
You want me here? Okay.
Yeah, it's good. And then maybe Alyssa.
Okay.
Yeah. All right. Thank you guys so much. That's wonderful. So I will just try to keep the conversation short because I know there are probably a lot of questions from the audience. And maybe I will just start by asking, since we already talked about mental illness and drug addiction, can we rely on self-reported data to get an accurate sense of how many people, what percentage of people unsheltered, homeless, are suffering from mental illness and or drug addiction?
You want to go first?
Yeah, sure.
The first answer is no. Of course you can't, because there's a social stigma and it's often illegal to be using drugs on the street. That being said, I have found people, particularly in San Francisco, but really across California, to be pretty open these days about their drug use. And you can go on to my Twitter page or my YouTube page and you can see my interviews with people. Even the ones that sort of deny drug use will then acknowledge it within about 5 or 10 minutes of us sitting down and talking with them about it. I would also just want to say I'm not sure it matters. In other words, we need to do Cal Psych, shelter first housing earned, and enforce laws, whether 25% of the people on the streets are addicts or 95%. It doesn't matter. We need the systems in place. We need the institutions in place to solve this problem, regardless over who's right or wrong in this particularly academic debate about how many people on the streets are addicts or mentally ill.
So I'll just add that with the question of whether or not you can trust self-reporting when it comes to severe mental illness, you definitely can't, because about 40% of people suffer from a condition called anosognosia, so they don't actually recognize their own illness. They have a neurological difference that makes it impossible for them to perceive the symptoms of their illness. So obviously, if you were to ask somebody and they said they did not have mental illness, 40% of the time they could be completely wrong, and if you just took their word for it, you would also be wrong.
Anna, anything?
I don't have much to add, just it's all context dependent. You know, if they're in a situation where they feel safe, then they'll disclose, and if they don't and there are negative consequences, they may not.
I feel a lot of times we don't feel comfortable of talking about mental illness and drug addiction because we don't want to stigmatize this specific subset of the population. So what shall we do?
We should talk about it. The fear of not talking about it, the fear of the stigma reinforces the stigma. We should talk about it. When I interview people on the street, I ask them, I just go, so what's your drug of choice? Super normal, super matter-of-factly. I similarly ask women, I ask men too. Have you been assaulted? Have you been assaulted more than once? What was the situation like that? You know, we're in a state and in a community and in a moment where people are obsessed with being trauma-informed, but the people that are going on and on all the time about being trauma-informed want to remain trauma-disinformed, I find. They don't want to talk about it. I mean, every time I talk about it, and I mentioned I described this in San Francisco, there's usually somebody that's out there accusing me of stigmatizing people for wanting to talk about it. So yeah, we absolutely have to talk. We have to talk about it openly. We need stories. We need people to tell their stories. We need recovering addicts in particular to tell their stories. Victimization is not the end of the story. Being a victim, being an addict is not the end of the story. It's a moment in a process of becoming a hero. And so there's a heroism of recovery. We need to elevate those stories, the stories of recovery, not just the stories of addiction and of mental illness.
I don't really like to emphasize stigma as a major cause of why people don't get treatment. It's not that it isn't real. Stigma is a real thing. But I also think that, the part of stigma that people kind of don't talk about, which to me is a much bigger driver, is the systemic stigmatization of mental illness. And what I mean by that is our decision that we aren't going to address mental illness by not requiring companies to pay for their care, by allowing awareness campaigns to replace outreach campaigns. I think stigma is something that gets trotted out all the time is something that we should focus on first. And as soon as we eliminate stigma, then we'll worry about treating illnesses. And we're never going to get there. So I think I would much rather focus on the discrimination factor that is systemic in nature, because the responsibility, I can't control what individuals think, but we should have an expectation from our systems that they won't treat this kind of illness and only this kind of illness differently.
Anna?
Yeah, I really like that. And I would add that the disease model of addiction, I think, has really helped us not just reduce stigma, but advocate for the building of an infrastructure to actually treat people with the disease of addiction and support research to study addiction. So I think that's really key, the systemic piece. I get paid by relative value units, as most doctors do at Stanford, and I make in 10 minutes the same amount of relative value units that I make in an hour what an ophthalmologist makes in 10 minutes. So our whole healthcare system does not incentivize or reimburse mental health treatment, and that's really the biggest crime of all, because people won't do that work if you don't pay them to do it.
Thank you. I guess my next question is for Lisa, in particular, because you're an expert on mental illness. So we know that a lot of people now are not receiving proper and adequate treatment for their mental illness. So how did we get here? Could you walk us through some historical background?
Sure. The way we ended up here, where the primary places where you find people receiving any kind of treatment, or at least where you find the largest populations of people who are mentally ill, either would be within homeless populations, but probably more importantly in jails and prisons, is because as we decreased our hospital bed census, we did absolutely nothing to replace it with anything else, which I know we've talked about a little bit in earlier sessions today, but I can't really overemphasize the impact that has had. And because you can actually see there's a direct relationship between, as hospital beds began to taper and disappear, the population that used to be in those beds began to be in jails and prisons. It's an exact replica. So that is how we ended up there. It's not the only factor, but it's certainly a big one, because not having treatment beds available for people basically led to a situation where individuals didn't really have an alternative, and the longer that they remained in the community untreated, the more likely they were to run into law enforcement, end up in the criminal justice system, and find themselves criminalized. That is really where we are. We do not actually treat mental illness. We punish symptoms of mental illness.
Thank you. So besides the shortage in mental health treatment, what about drug treatment? Do we also have a shortage? I guess Anna and Michael, do you guys know anything about that?
So I guess I'm going to piggyback a little bit on what Lisa was saying. First of all, I think an important message out there is that we have effective treatments for addiction, and that treatment works, and we can be very hopeful about that. And it's often a myth that people think that people with addiction will always be addicted, won't get into recovery, and that's absolutely not true. But it's also true that you need a functioning prefrontal cortex for addiction to treatment to work, because it really relies on the ability of that person to engage in the biopsychosocial kinds of interventions that we know work. So who are the people in the population, as I alluded to, who don't have a fully functioning prefrontal cortex? Teenagers, right, which is why they're difficult to treat. Older people who are demented, and then people with certain types of severe mental illness. So although I would want you to leave here knowing that we have a lot of good and effective evidence-based treatments for addiction, I don't want you to be naive about the fact that there are people for whom our addiction treatments don't work. And for those individuals, access is not going to make a difference, which is, again, why I emphasize for a subset of the severely mentally ill and addicted individuals, we really need to create a therapeutic and probably locked environment for them to live. I have treated many, many young people, especially with schizophrenia and severe methamphetamine addiction, from wonderful families who will not be able to not use drugs as long as they have access to those drugs. And it's just absolutely devastating for these families. And there really is no solution except for a locked facility.
Michael, you have anything to add?
I just admire your bravery. I do. I mean, wow. I think I'm going to make a couple of points. I think the first is that for me, before I got into this research, treatment meant something that was done to you. And I like the use of the word recovery. And I think you said it really well, Anna, in your talk, which is it's about reestablishing the agency of the person. People, one of the responses that we hear a lot is people say, well, people have to hit bottom. And I think there's a lot of truth to that. I think that we're lowering the bottom in California. We're reducing the consequences for people's own behaviors. We need to raise the bottom. So I think that is a helpful metaphor. But I do think we sometimes go, and I agree with you also that I do think that the medical model is helpful here. But I do think it has this implication. I think people hear it as though we just go bring an addict to a rehab center and then something is given to them. And then this is a Suboxone illusion. We give them Suboxone and they'll be fine. Right. There's a very famous harm reduction advocate who was a huge advocate of Suboxone who just OD'd a few weeks ago. We can't quite figure out exactly what's going on, but we see this quite a bit. We know that it has to come from within, and so I think that that's part of the challenge here. I think the other thing is that there's still this huge overhang of One Flew Over the Cuckoo's Nest. It's an old movie that's not psychiatry anymore. It probably really wasn't psychiatry back then either, but that's just such a huge overhang. Like when you read Sheila Kuehl describing why she's a LA City Council member, why she's opposed to expanding conservatorship. Look at the response to Britney Spears. We don't know what the deal is with Britney Spears and her dad. We just don't know. Like nobody knows. But if you look at the response to that, I watched the HBO documentary, the New York Times documentary with my wife, and it was instantly that she was being victimized by the medical system. So I do think one of the realities is that a lot of people, that because America also is just obsessed with freedom in ways that the Netherlands isn't. In the Netherlands, the social workers, they can put some pressure on you, in ways that are a little off the books to get you into the help you need. We would have ACLU lawsuits like that if they did the kind of things here that they do in the Netherlands. So the consequence of that, unfortunately, is a lot of people are going to get an interaction with law enforcement before they get the help they need. I agree with you. That's not the way I would want it. That's not the way I would want it for myself or for my kids. But I think that is part of the reality here. We were talking before the talk about insight and this issue of people not having insight, and I kind of left some of that stuff out of the book, in part because it just really freaks out Americans that you would have a doctor deciding whether or not you're mentally ill before you've committed any crime or done anything. So I think this is a really tricky area. And it is one of the reasons I want to sort of defend the role of police in helping people to get that care they need, because I think in some ways that's easier for Americans to get their heads around than allowing a bunch of psychiatrists to decide who's mentally ill and who's not, and who should get treatment and conservatorship and who shouldn't.
Should we open up to the floor? I forgot.
Her hand went up right so quick. You must have something
5
interesting.
minutes.
Yeah,
let's open up to the floor then.
I'm going to abuse this. you guys have provided this great lens into, like how to think about addiction and all of this. One of the ways in which the US is very different than the Netherlands is that we have a real history of racism. We talked this morning about how racism shows up in systemic ways, in terms of our employment system, in terms of our housing system, in terms of our policing. And so do you guys want to talk a little bit about how, what you're recommending intersects with that?
Well, I'll jump in there. I think we can look to other countries for models, but we have to be really careful about assuming that importing that model will work in our countries. So for example, drug courts. HOPE is an example of a drug court system in Hawaii, which was very effective, using contingency management to shape behavior of people with addiction in the criminal justice system to get them into recovery. What is contingency management? It's the use of punishment and reward commensurate with the transgression in real time in order to shape behavior. A wonderful example of contingency management in this country is South Dakota's 24/7 sobriety, where they have an active recidivism problem with DUI offenders. And typically what they would do for a DUI offender was say, well, you're now going to have to go back into the court system and possibly 2 years from now go to prison. And that had zero impact on the people who were relapsing and getting more DUIs. Then they changed it to contingency management, and they made the punishment swift and immediate. They said you have to wear a bracelet if you consume alcohol while you're supposed to be, on probation. You have to spend that night in jail, and then you're released. And they saw a 10 to 20% reduction in their DUI recidivism rate. So there's a good example of the criminal justice system interfacing with people with addiction to use contingency management in order to shape behavior in a positive direction. So getting back to your question, the drug court, the HOPE drug system, was imported to a place like Oregon, and it failed miserably. And we're not really sure why, but it just didn't work. Also, same thing with safe injection sites, which seem to work in some communities, but are an unmitigated disaster in others. It's just a way to speak more broadly to this issue that we can look for models in other contexts, but we have to be really respectful of the impact of that context, including issues of racism and our historical legacy for whether or not that system will work.
I guess before I open up to the floor, I do have one remaining question for Lisa. I do really want to ask you about care court and how is that going to be different from Laura's Law, for example?
Okay, so care courts are still in the process of being made into sausage, so we don't really know exactly what they're going to be. So, there's still a lot up in the air. Prior attempts to kind of get at the issue of what do we mean when we say gravely disabled have definitely in committee really been changed a lot from how it was introduced. So we don't know what this is going to end up looking like. But I will say that there are 3 things about care courts that I really like, and I really hope that whatever ends up coming out contains these 3 things, because they'd be a big improvement one way or the other. One of them is the fact that they are meant to prioritize this population. So they really specifically do, this is meant for individuals that have psychosis as part of their illness. It's really one of the first times that any attempt has been made to prioritize this extraordinarily overlooked population. That's a big deal. The other thing is that it does open up the ability to initiate the process. So it gives direct access to the courts to people other than law enforcement and other than hospitals. That actually doesn't exist in California, which I think a lot of people don't maybe know. But if you actually wanted to initiate a 5150 in California, you really only have a couple of options, and individuals don't have the ability to petition the courts and start a process. Now, that's not always the way that these things get started, but it's like not having that as a safety valve means that the decision about whether or not somebody is really doing poorly enough that they need help is in the hands of people who have like a 15-second interaction with that person. You really don't get a full picture. You're not, a lot of times they don't even, there's not an opportunity for people who see somebody every day to say, here's what I've noticed. Here's a pattern that I know that this person follows. This is what happened the last 3 times that this person was in this cycle. So that's a really big deal. And it's something that, Laura's Law has it adds a little bit so that you can actually petition the system, but you're still petitioning the system to see if somebody can get into Laura's Law. They're required to do an investigation, but you really can't have access to the courts. So that's a big deal.
Sorry, just to clarify, so a family member could initiate a 5150 on someone in their family or someone they were worried about? Is that what care courts?
No, they can't. What they can do is they can call 911.
But I mean, with care courts, that would change, right?
Oh, they can. It's not a 5150, but they can initiate. They are designed so that the individual can be petition to start the process of care courts.
A family member.
Actually,
yeah.
it's set up so any individual that has the requisite knowledge to file that petition can start the process. It doesn't mean that it's granted, but it means you can start the process. You have access to the courts. So that's one thing. And then the thing that I like the best about care courts, which has come up a little bit so far today, is that it has a mechanism to actually hold counties to task if they don't willingly treat this population. You're ordering individuals to be a part of this process, but you're actually also able to penalize the counties if they don't follow through and make those services available. And I think a lot of people who work in this system are aware of the fact that this is really where things are falling down in California, is that if people don't want to have as clients really difficult patients who really don't want to be part of it, they can just ignore them. They do. They're invisible to the system. If they're not actually actively seeking care, they're not going to get care, and nobody's going to bother anybody about that. And it works great for people who are trying to avoid care, only in that they're not receiving care. Everything else is terrible. But it also basically lets the counties off the hook for providing the care that is needed for like the really tough end of the spectrum. And care courts actually does have a mechanism that would prevent that, which I hope that stays in there because that's new. That would be a really big deal for California.
And what is that mechanism?
It's a financial mechanism where they can fine like $1,000 a day for counties that are not providing services when if the person has been identified as being eligible for care court and the county is ordered to provide those services. If they don't, then they are going to lose money. And that's one of the only things I can think of that might actually get action.
I don't think it's going to work. I'll tell you right now, because it's the same thing that he's trying to do with the building more housing. You know, the governor says, we're going to fine the counties, they're going to sue Huntington Beach if they don't build more housing. In that case, I'm not sure that there's an alternative. But the other alternative is you have a single statewide system, a single agency that is responsible for it. Otherwise, that care courts, I mean, I'm glad you've articulated it. It depends on our existing county-based care system, which is fundamentally broken. I don't think it can work. 58 counties offering duplicative services, overlapping services, so you get these redundancies and gaps in the system. They're saying we're going to overlay to this broken system yet another court system, and then we're going to punish counties $1,000 a day. I got to say, color me very skeptical of that. I think you need a proper care system where there's hierarchies, where there's people who are in trouble, like not a fine down the road, but like you have to take care of that person now, or if you're not, then you're fired, or somebody else will get in there and do it.
Well, I will say that, I think that that's fair, but I also think that setting up a statewide system takes a long time, and we need to do something now.
I don't think it has to take a long time. I mean, why would it?
Because it doesn't.
I mean...
I guess I see Mark has a question over there for a long time.
Okay, so I'm just going to shift things a little bit. So in 2009 and 2010, I was very proud to work on President Obama's Council of Economic Advisors. And what I worked on was Obamacare. And as a result of Obamacare, 100 months ago in California, the state initiated the biggest ever expansion of a program called Medi-Cal. And beginning January 2014, if you look a couple months before January 2014, there were 8.5 million Californians on Medi-Cal. 6 months after January 2014, there were 13 million Californians on Medi-Cal. 4.5 million increment to the number of people getting health insurance in California, differentially males, differentially young adult males, tens of billions of dollars from the federal government has poured into California's healthcare system as a result of this. I worked this is something I'm super proud of, but it's kind of a mystery to me when I think of, and I didn't think of this until today, Jalou, when you presented and hearing the conversations today. Things went off the rails for some reason in California in 2014. The trend, you see the trend break, right? From 2014 to 2020, the number of people who are homeless in California went up 42% in per capita terms. Texas, for example, no expansion of Medicaid there, declined during this time period. I guess then you add to this 1% tax that brings the California top marginal rate to 13.3% on millionaires, which we heard from the mayor of Sacramento, $3.8 billion this year flowing into the healthcare system. I'm just kind of confused. How is that, all of that additional money, not helping the very people we are talking about here? It is kind of a mystery to me. I worked on Obamacare. I'm super proud of it. I have papers saying it did some great things. But I'm just kind of baffled. It was billed as the biggest change in domestic public policy since the introduction of Medicare and Medicaid in 1965. It coincides with exactly where things, do any of you have any idea? I'm a health economist. I like to see what's the bang for the buck of incremental spending. Do you just know, didn't matter? Did it not help at all?
I can talk a little bit about Prop 63, and part of what the issue is there is that the counties are sitting on a lot of that money instead of spending it. That's a problem. There's also the fact that the Little Hoover Commission over and over again has come up with the same idea that basically we don't have enough top-down oversight of this fund to make sure that this fund is actually going to who it's intended for. Now that fund was very specifically passed to target people with severe mental illness. Over and over again, we're finding that that the oversight isn't adequate to make sure that the money is actually going where it's supposed to be going, and as a result, we're not seeing the impacts that we might. But we don't really seem to have the ability to change that. So I do agree that part of this is that we need a little bit less of a local variant that can kind of do whatever it wants, and we do need some more top-down oversight to make sure that funds are actually used the way that they're supposed to be.
I think the problem is that we do not have a robust infrastructure inside the House of Medicine to treat mental health and addictive disorders. We have centers of excellence for cancer. We do a great job for all kinds of chronic illnesses, diabetes, heart disease. We do not have the workforce, and we do not have the infrastructure to treat mental health disorders and addiction. Those are often siloed, often separate entities. Even mental health and addiction are siloed and separate. So I think that's the huge problem, and we're trying now to build up that workforce with various incentives, but also I can tell you as a mental health care specialist, you're going to make a fraction of what a surgeon is going to make. So after all that time and all that debt, you don't have a lot of people who are super eager to go into mental health care treatment. A little bit of a silver lining, though, I can tell you that the biggest change in my professional career when it comes to insurance coverage was Obamacare, when for the very first time, because of the parity laws and the open exchange, people had at least insurance coverage to pay for mental health and addiction treatment, which they did not have in the first half of my career.
Okay, so I've just
thank
issued
you.
a challenge, though, to you, Anna. I should challenge you. If
Okay.
you can tell me what data set to look at
Oh, no, I
to
can't tell you
show that the $3.8 billion, and
just-
you know what I mean, improved mental health in California. I would just love to see it, because
Here's what
I want it to be true. I want it to have benefited.
No, I didn't
all
say
this
that. I'm validating that on a large scale, we don't have good access to those treatments because we don't have the infrastructure.
Okay, so it just didn't improve things.
We don't have the workforce, we don't have the infrastructure. But for people who had the wherewithal, for whatever reason, to use insurance to get the treatment, those people at least get it paid for now. That's my point.
Okay, so yes, right. And remember, I did address this. Huge amounts of money has gone into this space, and yet we don't have the beds. We don't have the psychiatric beds in the hospitals. We don't have the shelters. I was just in Fresno, and the shelters were full. The women were, these people were outside because they couldn't get in the shelters. We don't have the rehab.
We don't have the detox.
We don't have the detox.
There's no
We don't have the
detox.
group homes. So you're asking, where did the money go instead? Am I right?
Sure,
The
yeah.
money went into housing first. So it goes into $750,000 per unit housing complexes. very expensive housing. It goes into nonprofits that do not implement these, that does not do this work. I mean, that explains it.
Yeah,
There's
I need an answer when my friends at UT Austin and Texas
Yeah.
A&M taunt me and say, Mark, you guys expanded Obamacare. We didn't. And it actually looks like things have gotten worse in California. Anyway, so I want to come back and, anyway, thank you. But I
So
think
maybe this gentleman here, Denia's husband.
Proud to finally be identified as Danae's husband. I've been waiting for that. All right. This might be a question for you, Michael. I've read your book, found it incredibly fascinating. And to your question, Mark, around timing, 2014, 2015, Prop 47 and decriminalization, several folks have talked about law enforcement's inability to actually do anything about this on the streets right now. And a lot of what you talked about says that they will be able to going forward. What happens to Prop 47 in your proposal?
It almost certainly needs to be reformed.
Can you go into a little more depth on that?
Well, that's a policy question, right? I mean, I'm not...
Policy questions are allowed, but not campaign questions. We're not allowed to say, if he becomes the governor, what's he going to do?
I was just going to say, what should happen?
No, I'm talking about specifically to, an idea like CalPsych or something like this, like whatever you want to call it, whoever does it.
Yeah.
When you're
Just
talking
policy,
about
it's fine.
law enforcement on the streets being able to help that situation, they're there with a mental health professional, they're law enforcement. What can actually be done because all of these drug enforcements have been declassified to misdemeanors. I've spoken with a lot of law enforcement in Sacramento, where we're from. The best they can do is give somebody a citation, but nothing's actually happening. And then, to your point, Anna, it's access, right? So it doesn't just start in the city, it's happening in the suburbs. The access is in the suburbs. These people, like you wrote in your book, are then ending up in the city, and that's where we're seeing the problem. The unseen problem is actually happening in the suburbs because of the access to these illicit drugs.
So the short answer is we don't know how many people we can get off the street into rehab, psych beds, shelters, group homes under existing laws. I think a lot. Quantifying it is impossible without changing those laws. How many would we would need to change Prop 47. I give that example where somebody ODs on the street and you're like, you can come into rehab or you can go to jail by the office. That assumes that if they have under 3 grams of drugs under Prop 47, that's a misdemeanor. Now, if it's a misdemeanor, you can still arrest them or cite them. If there's public camping, if there's other things going on, if it's a chop shop and there's obviously goods there, one bite can be worth more than $950. So we don't know how many people we get off the street if we had a proper care system. So you basically have an argument here where there's progressives who are like, we don't have a proper psychiatric addiction care system. They're right, we don't. That's why we need CalPsych. You have conservatives who say we don't have the law enforcement tools to get people into rehab. They're also right. So my argument is, let's start with the care system. We've got the money. You've got the goodwill for it in a state that's pretty darn liberal. And let's see how much of this problem we can address without adding criminal penalties, which Californians have been pretty reluctant to do. I do think we're going to need to bring back some of them, but we just don't know. In terms of the money, just so you know, David Chu, Tom Insel, the LAO, they can't figure out where the money's going. So, it's not like it's been looked at. At a certain point, I was just kind of like, with the book, you're like, housing, very expensive housing, a lot of nonprofits, a lot of service providers, and yet we still don't have the facilities. So now you can spend a lot. I've had various people be like, we need to do an audit. Great, but at the end of the day, you still need the psychiatric and addiction care system, and you still need the services working with law enforcement to get people into care. At the end of the day, you still have to take action.
Okay, we probably have 3 questions. So here we have one, and then one in the back, and then the lady in black.
Could you just tell us what you're thinking about the numbers and types of professionals required to staff this statewide system?
Yeah, I would say the most expensive part of the system is the psychiatrists, folks like Anna. The good news is that most people don't need, they don't need a psychiatrist for many hours. They need some sort of a diagnosis. Physician's assistants, nurse practitioners can prescribe Suboxone or methadone. Like if you have a CalPsych van or CalPsych vans up and down California, they don't need to have MDs in them. They don't need to have psychiatrists in them. They could be EMTs. So there's a lot of that. There's also, we just need a lot of rehab facilities. I mean, it is daunting, the amount of facilities we would need. On the other hand, we have and this is one of the craziest things. We have so much money and we don't have the workforce.
Sorry, I just want to jump in. What we really, we don't need vans with buprenorphine. We need hospital beds for people to detox.
Yep.
We need sober living environments. We need long-term residential facilities, and we need locked facilities. We need beds. We need treatment, housing, those things combined.
Amen.
You need some vans too.
That's very good. Thank you. I really appreciate your knowledge, but I think it's a panel up there, and it's not just you. You're pretty much, in my opinion, taking over, and that's okay for
Sorry.
them, but
I'll
not
talk
for
less.
me. I'm a licensed alcohol and drug counselor, and I'm retired. I worked in the Santa Clara County with drug treatment court, very successful. This is where they had people with addictions under the jurisdiction of the judge and the criminal justice. They walked them through. They engaged them in mental health through Dr. Fu and other doctors. It's a wraparound service provider, and I've seen a lot of success. Now I'm currently an outreach case manager for We Hope, dealing with substance use, dealing with homelessness, dealing with mental health on a daily basis. What I've noticed a lot we haven't discussed was sleep deprivation. Now, I know mental health is definitely a medical issue, but because of substance use and also not being able to get sleep, we get a lot of sleep deprivation, which looks like mental health because they're not seriously getting enough rest for them to act functionally. My concern right now is we need to work more together to deal with wraparound services that will deal with the substance use, that will deal with the THUs, the sobriety living, that will deal with the mental health. It will deal with all these components that are keeping our unhoused people unhoused. I would like for us to spend a little bit more time listening to all of us instead of one or two people where really one person taking over the whole panel. And that's just my opinion.
Appreciate that. I was being asked questions directly, but okay.
And I guess the lady in black.
Thank you.
Go ahead.
Oh, that's all right, thank you.
So,
Who's next? You're both wearing
go right
black.
ahead. I'm sorry. I'm so sorry.
All right?
Go ahead.
Okay. Well, you might wish it was the other way around, but that's okay. My name's Helene Schneider. I'm with the U.S. Interagency Council on Homelessness. I'm a former elected official in the state of California in local office. I just bring that up as context to respectfully but very strongly disagree with your assessment of Housing First. Housing First is not housing only. It's wraparound services dedicated to the person involved in whatever is necessary. It is not being scaled up the way it should be. I think everyone, earlier today we talked about veteran homelessness. From 2010 to 2020, veteran homelessness went down by over 50%, including California where, as we heard earlier, it almost flatlined when other areas was going up. That is the combination of housing with needed supportive services around it. I think one of the things to get to the question of what happened in 2014 and the number of units or number of people experiencing homelessness going up in California in particular, we have to remember there was a thing called the Redevelopment Agency, which was not perfect at all, but did provide $1 billion every year directly to capital of affordable housing. Over time, we've lost that money. We've lost $1 billion a year now for over a decade. So finding that new source of funding is really something of a policy issue we need to address. It's almost 3, it's almost the time we can, talk more and debate more about that. But I do think in terms of Housing First, the $750,000 per unit, whole lot of other issues we talked about today. My question, just to get to the other side, is what would a housing and surrounded services look like in your mind that would work in terms of the collaborative nature that would have to require between your housing authorities, your mental health services, your counties, and other agencies involved to make that work to scale in California? Thank you. Well, I mean, I am not an expert on housing policy, but I will tell you that for a population that it has psychosis as sort of the root of the issue, I think treatment needs to be prioritized before housing, and that's based somewhat on personal experience with, a relative that I have who, her reasons for being homeless, really, she had a place to go, she thought it was haunted. And so her being there without being treated would have not solved the issue. So I just always think of her, and I think of people who are in that situation, and I think, would it work? And for her, that wouldn't work. So I need a system that would actually be able to help her.
I'll jump in there and just venture to say that I think it needs to start with a detox bed and then treatment for addiction, which begins after detox is over. So a safe, and I will call it restricted environment where the individual doesn't have access to drugs, can get their limbic system and their prefrontal cortex reconnected, can get any additional psychiatric medications or treatment that they need, can get a good outpatient plan, and then can go into either sober living environment. These are communities that we really know make a difference. The evidence is very strong, so that they can at least have a fighting chance to manage their dual diagnosis going forward. That's not housing first, but it's a kind of housing. It's a recognition that shelter matters. Yes.
To fix the damn problem, and we're getting divisive.
That's
I just
okay.
want to make sure I understand, because everyone remembers I'm sleep deprived. So what you just said, what you both experts just said, was you have to treat stuff first, not give them a house first. That's what I heard, right?
It is my belief, based on my experience treating people with addiction and co-occurring mental health disorders, that you have to mandate treatment in many of those individuals, and you have to restrict their access long enough for them to get their prefrontal cortex functioning so that they can make informed choices. So if you want to say that that's not housing first, then I agree with you, it's not housing first. But to me, it's a type of housing. What we're saying is you can't get somebody well who's living on the street.
Right.
Well, I would just say that there is an option that we're not really talking about, and it's you could actually stabilize people before you discharge them, and then maybe housing first would work. But we're nowhere near that. People are in the hospital for maybe 2 days.
Michael, last words, and I see Mark is right there, so we're gonna. Oh, right, okay. Last question, maybe. Last question.
Yes. So my question is kind of twofold. So one thing that you mentioned was getting the police involved in handling the mentally ill. Well, I don't know how that works outside of the people of color community, but I've personally witnessed the police being called in on a person of color who was mentally ill. They were told in advance that the person was mentally ill, and to apprehend them, they dislocated their shoulder, they slammed their foot in the door. And so for me, without them being professionally trained on how to deal with people with mental illness, I wouldn't want them involved at all. And I'd like to hear your response on that. And then the other part is that, I'm sorry, I can't even mention the other part right now, I'm a little emotional, but if you could at least speak on that.
I think she was asking me, and I just want to say I was asked directly, I believe, and I can hear the emotion in your voice on that. My aunt suffered schizophrenia. She was badly treated at the beginning. I totally understand, and obviously that's the problem we don't want to have. We need people to get the care they need before law enforcement gets involved. My point is that I find that in my conversations and my research, there are very many people in our state that are not comfortable imposing mandatory treatment on people who have not broken any rules. They're comfortable with voluntary treatment. And so that leads to a problem when somebody with mental illness or in a psychotic state for whatever reason, whether from underlying mental illness or from meth or whatever, is engaging in illegal behavior or threatening behavior, violent behavior, that often is a moment that law enforcement does get involved. Should the law enforcement be better trained? Absolutely. Do we want to get people the care they need? Absolutely. It's clearly not happening now, which is why I agree we need a statewide psychiatric addiction care system. We need the facilities that we've all been talking about here, And I think we need to have a good relationship between social services and police rather than excluding police, because they're going to be involved no matter what.
Well, I just want to say that I actually agree with you that and we diverge on this. I don't think that you want to have any more interactions between individuals with mental illness, particularly mental illness, and people of color and law enforcement than you absolutely need. Now, there are going to be interactions between people who are in crisis and law enforcement, where like law enforcement has to be there because maybe there's a weapon or what have you. But generally speaking, it's just a bad matchup. People who are in law enforcement have a limited number of moves that they can make. And people who have severe mental illness and have cognitive dysfunction, especially if they're in psychosis, do not behave in predictable ways. So the way that you avoid that interaction, because you can't always, but the way that you avoid it is you have to be willing to intervene earlier, before a person is in a flat-out emergency, before you have to call 911. And I hate to say this because I know it's not super popular, but this is kind of the problem that we have, is that people really want to think of involuntary treatment as being the absolute last thing that you should be willing to do. But if you do that, if you have the belief that you have to wait until you have no other options, you will be calling 911.
Okay, I see Mark is standing there, so we probably should get out of here, but let's thank all the great panelists. Thank you so much.